Auzubillahiminash-shaytanir-rajeem. Bismillahir-rahmanir-rahim. Today we are going to discuss the antepartum hemorrhage, Clinical Guideline number 63, and it's been published in November 2011. First of all, the background of antepartum hemorrhage. Antepartum hemorrhage is defined as antepartum hemorrhage. It is defined as bleeding from or into the genital tract occurring from 24 weeks of pregnancy and prior to the birth of the baby. The most common causes are the placenta previa and the placental abruption, and 3 to 5% of pregnancies are affected by APH. And the leading cause of perinatal and maternal mortality worldwide. Up to the one-fifth of very preterm babies which were born with APH, they are known to have cerebral palsy, which is explained by preterm delivery. In the UK CMAC inquiries, hemorrhage being the sixth largest direct cause of maternal death known so far. Now coming to the discussion how we are going to classify the antepartum hemorrhage. It can be spotting, it can be straining, streaking, and mild spotting noted on the undergarments. And minor hemorrhage, this is defined as the blood loss less than 50 ml that has been settled. And the major is 50 to 1000 ml with no signs of clinical shock. And in the massive hemorrhage, when the blood loss is greater than 1000 ml and the signs of clinical shock are present. And in recurrent episodes, there are multiple episodes of antepartum hemorrhage or one or more occasions. Now coming to the risk factors for the placental abruptions, these are defined as uh, the major reported incidence of recurrent abruption is 4 to 4.4%, and in 19 to 25% of women who have had two previous pregnancies complicated by abruption, they experience abruption in the third pregnancy as well. The risk factors for placental abruption are the preeclampsia, fetal growth restriction, non-vertex presentations, polyhydramnios, preeclampsia, fetal growth restrictions, polyhydramnios, non-vertex presentations, increased maternal age, multiparity, low BMI, pregnancies conceived by the assisted reproductive techniques, maternal infections from and drug misuse, trauma in pregnancy, smoking, and from maternal thrombophilias in which heterozygous prothrombin mutation and factor V Leiden mutation is present. And those pregnancies which were having first trimester pregnancies can experience placental abruption. Now coming to the further details, those pregnancies which have factor 5 hidden mutation, these have odds ratio of 4.7%, and those who have prothrombin mutation, heterozygous prothrombin mutation, it has odds ratio of 7.7. So if there is an option or in an MCQ where prothrombin mutation and heterozygous factor 5 hidden mutation is present, then we have to choose the most commonly prothrombin mutation. It has a more incidence, more odds ratio, 7%, and in factor 5 hidden there is 4.7%, like 5%. Okay, what are the risk factors for the placenta previa? In placenta previa, um, like if patient is having a previous placenta previa, there are odds ratio of 9.7%, like 10%. Previous cesarean sections, risk factors are 2.6%. One previous cesarean section odds ratio is 2. Two previous cesarean sections odds ratio is 4%, double than the previous, and in 3 that is 22%. And the previous termination of pregnancy, multiparity, advanced maternal age, multiple pregnancy, smoking, deficient endometrium due to presence or history of the uterine scarring, endometritis, removal of the placenta, curettage, submucosal fibroids, or assisted conceptions. Now coming to the question, can APH be predicted? APH has a heterogeneous pathophysiology and cannot reliably be predicted. And can APH be prevented? Women should be advised and encouraged and helped to change modifiable risk factors to prevent APH, such as the smoking and drug misuse. In cases of placental abruption, those women who continue to smoke, they have low birth weight and preterm delivery. And folic acid supplementation role is controversial. There is a systematic review which does not support the folic acid supplementation. However, an observational study is conducted in the Norway estimated that vitamin supplementation and the risk of placental abruption was lesser in those women who were fortified with folic acid and multivitamins during pregnancy, and hence significantly less likely than the non-users to develop placental abruption. And there is no good data to support a role of antithrombotic therapy like low molecular weight heparin and aspirin, low dose aspirin, in the prevention of abruption in women with thrombophilia. Now coming to the hemorrhage from placenta previa, it is considered a good practice to avoid vaginal and rectal examinations in women with placenta previa, and to advise these women to avoid penetrative sexual intercourse. Um, Cervical surplus to prevent or reduce bleeding and to prolong pregnancy in cases of placenta previa is not supported by sufficient evidence to recommend this practice outside a clinical trial. So, in patients who are having hemorrhage via placenta previa, cervical surplus, to prolong the pregnancy and to reduce the bleeding is not supported. And there is no place for the use of prophylactic tocolytics in women with previa to prevent bleeding. What are the complications of APH? They are maternal complications and the fetal complications. In cases of maternal complications, there occurs the anemia, infection, maternal shock, renal tubular necrosis, consumption coagulopathy, peripartum hemorrhage, prolonged hospital stay, psychological sequelae, and complications of blood transfusion. I repeat, anemia, infections, maternal shock, renal tubular necrosis, consumptive coagulopathy, postpartum hemorrhage, prolonged hospital stay, psychological sequelae, and complications of blood transfusion. In cases of fetal complications, there occurs the fetal hypoxia, small gestational age, and the fetal growth restriction, prematurity, iatrogenic or spontaneous, and fetal death. Is APH associated with any specific pregnancy complications and its outcomes? Um, Health professionals should be aware that the domestic violence in pregnancy may result in APH, and domestic violence in APH may result a woman with more morbidities, and the potential consequences should be discussed. And antepartum hemorrhage is associated with the maternal and perinatal morbidity and mortality. Clinicians managing the woman with APH should be aware that of these the potential consequences. APH is associated with complications for the mother and her baby when hemorrhage is due to the placental cause like abruption or previa, when the bleeding is heavy, and when the bleeding occurs at early gestation. They should be explained for such complications. In women who have experienced unexplained antepartum hemorrhage are also at increased risk of adverse maternal and perinatal outcomes, such as preterm delivery, stillbirth, fetal anomalies. So there is a great woman who has unexplained antepartum hemorrhage are at greater risk of preterm delivery and undergoing induction of labor at term. And there is likely admission of the neonatal increased NICU units stay and hyperbilirubinemia, and they tend to have a smaller baby as compared to the term babies, and their birth weight was adjusted for gestational age and delivery and other confounders. Where should the woman presenting with APH be managed? All vaginal bleeding to their antenatal care provider, midwifery-led maternity unit where there is a general practitioner, or to an accident and emergency department should be assessed, stabilized if necessary, and transferred to a hospital maternity unit with the facilities for resuscitation such as anesthetic support and the blood transfusion resources, and performing emergency operative delivery. A multidisciplinary team including midwifery and obstetric staff, immediate access to the laboratory theater, neonatal and anesthetic services should be provided after the clinical assessment. Blood and blood products can be delivered in a timely manner. High risk, those women who are known to be high risk of hemorrhage, they should be managed in centers with facilities for blood transfusion, ICU care, and other interventions. What is the role of clinical assessment in women presenting with APH? Those women who are presenting with the APH in the first to establish whether urgent intervention is required to manage maternal or fetal compromise. This includes the triage process, which includes history taken to assess coexisting symptoms such as pain and assessment of the vaginal bleeding, cardiovascular condition of the mother, and assessment of the fetal well-being. Like history with the coexisting symptoms and the extent of vaginal bleeding, cardiovascular compromise or condition of the mother, and assessment of the fetal well-being. If they are having major or massive hemorrhage and woman is unable to provide the history due to compromised clinical state, an acute appraisal of the maternal well-being should be performed and resuscitation um, started immediately. In such situation, mother is the priority and should be stabilized prior to establishing the fetal condition. If there is no maternal fetal compromise, then the full history should be taken, like the clinical history, including the pain with the hemorrhage and placental abruption, should be considered when the pain is continuous. Labor should be considered if the pain is intermittent. Risk factors should be identified. Women should be aware of the fetal movement, and attempts should be made to auscultate the fetal heart. If the antepartum hemorrhage is associated with spontaneous or iatrogenic rupture of the fetal membrane, bleeding from a ruptured vasa previa should be considered. Previous cervical smear history may be useful in order to assess the possibility of neoplastic lesions of the cervix as cause of bleeding. The presentation of cervical cancer in pregnancy depends on the stage of diagnosis, lesion size, and the FIGO staging. In FIGO stage 1, women are mostly asymptomatic. A symptomatic woman usually present with APS mostly postcoital or vaginal discharge. Examination should be performed to assess the amount and cause of antepartum hemorrhage. After the primary survey is conducted, like airway, bleeding, circulation. Following the initial assessment and commencement of the resuscitation, causes for hemorrhage or collapse should be sought. Abdominal palpation should be assessed for the tenderness, like to rule out the acute abdomen. The tense and woody feel signifies significant abruption. Abdominal palpation may reveal the uterine contraction, and it suggests lower genital tract cause or bleeding from the placenta or vasa previa, like abruption, labor, lower genital tract trauma. Speculum examination. Speculum examination can be useful to identify the cervical dilatation or visualize on lower genital tract cause of antepartum hemorrhage. And cervical examination reveals a normal cervix in 21% of the women and cervical ectropion in 2% cases has the dilated cervix, and cervical ectropion was present in 21% of the cases, and 69% of the women had normal cervix. The clinically suspicious cervix should be referred for a colposcopic examination in line with guidelines from the British Society for Colposcopy and Cervical Pathology. Digital vaginal examination, if placenta previa is a possible diagnosis, and there was a previous scan showing low lying placenta with high possibility that high presentation on abdominal examination and the bleed has been painless. Digital examination should not be performed until an ultrasound has excluded the placenta previa. Digital vaginal examination can provide information on the cervical dilatation if APS is associated with pain or uterine activity.